My name is Liz Woodruff. I'm the Executive Director for the Idaho Academy of Family Physicians. And today for our July Grand Rounds, we have Dr. Tyler McShane from Full Circle Health, Boise, giving a presentation on aging and preventative care for adults with Down syndrome. We're very happy to have Dr. McShane here today. This event will run until 1:30. In the chat, you will see the opportunity to get CME for this event by filling out a short Google form. And if you're watching the recording, you will not be able to receive CME for this event. Just a quick reminder that our next Grand Rounds is August 14th, and it will be ERMAC that will be doing that presentation. I do not yet have a topic, but I'm sure it will be great. And we are starting our summer fall evening CME series on July 27th with a 1-hour CME presentation at 6 p.m. Mountain Time, 5 p.m. Pacific, Cultivating Resilience, Why Lifestyle is the Best Medicine. If you have questions, and I know this may be more difficult at ISU, but throughout the presentation, you're welcome to put your questions in the chat. Dr. McShane will answer questions at the conclusion of the presentation with about 10 minutes left. You can also unmute to ask your questions. And I did mute the ISU room, but hopefully you all can unmute it if you need to. So with that, I'm going to hand it over to Dr. McShane.
All right. Thank you, Liz. And thank you to the ISU crowd. Good to have you all here. Hopefully more people will trickle in. We'll go and get started. So I'm Tyler McShane. I'm a third-year resident here in Boise, planning to do kind of full spectrum rural family medicine when this all wraps up next year. And yeah, really excited to give this talk today. This is something I've been looking forward to for a long time because it's kind of an area that I'm trying to develop a little bit more into my own practice. So with that being said, I'm kind of starting from the standpoint of a beginner and not really an expert by any means, but hopefully I'll be able to teach you something and kind of answer any questions that you may have just based on all the research that I've been digging into for the last few weeks. So without further ado, I don't have any disclosures. And kind of what I'm trying to do today with this talk is answer questions that I've always kind of had about how we can tailor our preventative care strategies to adults with Down syndrome. What of our standard screening approaches are valid and apply to this group, and in cases where they're not so applicable, what should we be doing differently, whether that's more or less or just different approaches. I'd like to discuss a little bit about some of the kind of illness and health manifestations of Down syndrome, and then pick a few areas that I think really exemplify what it looks like to care for somebody who's aging with Down syndrome, and then we'll kind of dive deeper into the evidence of those areas. So to start with, kind of a historical perspective on Down syndrome over, the last several hundred years. It hasn't always been pretty. Going back to antiquity, typically infants were killed or abandoned. It wasn't until 1866 that the syndrome was first described by a physician in England who described it as Mongolism. Throughout the 20th century, kind of the defining approach was institutionalization. There wasn't a whole lot that was done to try and identify and manage medical conditions that may arise in Down syndrome. So in 1920, the average life expectancy was 9 years. Then came the eugenics era, and here in the United States, there were quite a few states that had programs of forced sterilization by Nazi Germany that had progressed to systematic murder. So in 1946, the average life expectancy was only 12 years. And then only after that did we really start making some progress. So the chromosomal underpinnings that we kind of know as trisomy 21, that was first identified and described in 1959 by Martha Gautier. And unsurprisingly, that was first attributed to her male colleagues before she finally got credit. And then by the 1970s, we were really beginning to see some progress in terms of life expectancy. So today, that's up to 60 years. And this is kind of a graphical representation of that history. So you see here sort of mean, median, 25th and 75th percentile. And, a lot of the advancements in terms of quality of life and life expectancy come from early correction of congenital heart defects. So for most of the history, that was really a big driver of infant mortality, was sort of not knowing how to diagnose and correct those. But other big advances have come from focused treatment of infections. There's often immunodeficiency that comes along with Down syndrome, as well as anatomic defects that predispose to infection. So that's been a big area of improvement. And so that's kind of where we're at today. This is the most common chromosomal abnormality in live births, 1 in 700 in the United States. As we know now, it's from triplication of the 21st chromosome. We've had big advances of life expectancy. And so what that means is that today, as opposed to maybe 50 years ago, we are seeing a lot more folks who are living into their 50s and 60s and beyond. And we kind of have some catching up to do in terms of our sort of foundational research, clinical research, and guidelines to, sort of direct how we care for these folks. So I think one thing that I want to kind of convey from my own learning over the last few weeks is that, I think when you're talking about illness and healthcare and Down syndrome, it helps to kind of conceptualize it from the standpoint of kind of three key domains. So the first is kind of the congenital defects and the anatomic differences that we see in Down syndrome, and those on their own can be big causes of morbidity and mortality. So congenital heart defects is a great example, as are some of, like the upper airway differences that predispose to like sleep apnea and recurrent otitis media, sinusitis, pneumonia, stuff like that. Then you have a pretty wide array of medical conditions that are just much more common in Down syndrome, both, in early life, infancy, and then also as people age. And then finally, something that we're coming to understand more is that there's a really central feature in Down syndrome of premature aging. So that's something that I'll talk a little bit more about. As we're looking through the data for evidence to kind of guide clinical recommendations for preventative care, there's really not a lot for adults. And so that's kind of a major theme that we'll talk about. Unfortunately, people have been excluded from trials for a number of reasons, and that's made it hard to kind of come up with concrete recommendations. So to kind of begin with premature aging, which I think is a really important part of this talk, we know that any gene that's located on chromosome 21 is going to be predisposed to overexpression. And so some of the key ones that we found are the beta amyloid precursor protein that's implicated in Alzheimer's disease. There's also the superoxide dismutase gene. That's something that's responsible for expression of and control of like reactive oxygen species. So oxidative stress is a big driver of aging that we see in Down syndrome. There are interferon receptors encoded on this gene, and so that can lead to neuroinflammation and neuronal loss. And so if you kind of look over here on the right side of the screen, again, this is kind of a graphical representation of the few of the things that I'll talk about. So visual impairment, hearing impairment, dementia. You can kind of see how these are all things that begin to express themselves in the blue dotted Down syndrome population, up to 3 or 4 decades earlier than we're kind of used to seeing them in the normal patterns of disease and aging that we're accustomed to. Co-occurring medical conditions. This comes from a really good review in the New England Journal of Medicine from 3 years ago. It's a pretty broad strokes and mostly deals with the pediatric population, which is kind of typical of the literature base in Down syndrome, but I think it really nicely encapsulates kind of the wide breadth of co-occurring illnesses that people with Down syndrome are predisposed to, and also just like the really high prevalence that we see in this population. So not just like congenital heart disease, but hearing deficits, really high prevalence, sleep disorders like OSA, leukemia. Interestingly, when it comes to solid tumors, that's actually one of the only things we're aware of where Down syndrome is actually protective for solid tumors, with the exception of testicular cancer. Hypothyroidism is really common. Celiac disease was something I wasn't aware of, JIA. So a lot of things to kind of keep in mind when it comes to monitoring. So I think because of the changes in life expectancy, Down syndrome is kind of an area where I think we know a lot more about the pediatric population than we do about the adult population. So kind of looking for evidence to guide, preventative care recommendations, it's largely lacking. There is a lot of basic science foundation to work with, and you'll see a lot of instances where experts will kind of try and extrapolate the bench work into clinical recommendations, but it really hasn't translated yet into actual clinical research to answer some of our key questions. And then in the areas where you do have solid research, some of the things you kind of run up against are small sample sizes, dealing with sampling bias, because it can be really hard to generate high-powered studies without some degree of sampling bias, sometimes conflicting results, and then really a lack of actual RCT interventional trials. I think in terms of clinical guidelines, the main one that I would draw attention to is this last one from JAMA, the 2 group from 2020. I would say that for me, this was probably the strongest set of recommendations that I came across in terms of guidelines for adults with Down syndrome. This came out of something called the Global Down Syndrome Foundation, who put together a working group of clinical experts. And what they did is they selected 9 topic areas to prioritize, and then did a pretty in-depth systematic review, where for each of these 9 topic areas, they picked a couple key questions that they wanted to answer. It's somewhat limited, I think with all of the co-occurring conditions that we already discussed, and with, you look at all of the, USPSTF recommendations out there for the general population, 9 areas doesn't get you very far. And what I found is that in a lot of instances, it's still kind of boiled down to expert consensus rather than real evidence-driven guidelines. And there were quite a few areas where they really felt like there wasn't sufficient evidence to kind of make a firm guideline or recommendation either for or against different screening practices. But I think it's a really good start. And my hope is that they'll kind of continue the work in this working group and be able to expand to include more areas. So anytime I kind of see a recommendation from this group, that's where I tend to put the most stock. On the pediatric side, I think there are much stronger sets of kind of rigorous evidence-based guidelines, and that comes from the AAP. They've been doing this since 1994, and they update it every several years, and I think it's pretty comprehensive. And so you'll also see some situations where experts will kind of extrapolate from the pediatric guidelines, especially for kind of younger adults. And then finally, to kind of touch on, how we're doing in terms of preventative care. There was a good study from 2020 or from 2012 that found kind of mixed results, with the most work remaining for evaluation of sleep apnea and then hearing and vision loss. So without further ado, I guess 3 areas that I think are, pretty exemplary of some of the patterns we see in aging and Down syndrome are Alzheimer's, vision and hearing loss, and osteoporosis. So I'd like to talk a little bit more about these and sort of what the evidence shows, what the data shows, and what the current guidelines are. Alzheimer's disease is very, very common in Down syndrome. We know that the amyloid precursor protein is located on chromosome 21, and that leads to excessive production of beta amyloid and plaque buildup in the brain. histologically speaking, by the age of 40, it's nearly universal that there's going to be proliferation of amyloid plaques and neurofibrillary tangles. So that's, across the board, almost everyone will have it by 40 with Down syndrome. That being said, the disease itself does not present universally by this age, and there are adults who will live well past 40, past 60, and never develop the disease itself, but the pathology is almost always there. There are also a few other genes on chromosome 21 that are hypothesized to have a role, including, again, that superoxide dismutase gene with the, oxidative stress and neuroinflammation probably contributing quite a bit. So a really good study from 2018 kind of detailed progression of prevalence of Alzheimer's disease throughout the lifespan. At the age of 40, when we know that histology or the histopathology is present, the disease itself is not super abundant at only 5%. But from that point onward, every decade or so, it roughly doubles, so that by the time you get to 65, the prevalence is 68 to 80%. They found a mean age of diagnosis of about 56 years, and then a median survival time after diagnosis of 3.78 years. It can be a really difficult diagnosis to confirm. You're essentially looking for decline in cognition, and that's sort of against the background of a baseline of cognitive impairment. And not only that, but also pretty variable expression of cognitive impairment throughout the Down syndrome population. And so kind of shoring up a firm kind of baseline functioning is a really important part of it. In terms of early manifestations, tends to follow the patterns of folks without Down syndrome in terms of the kind of early presentation. A few occasional differences. You're more likely to see changes in personality and behavior, more likely to see gait disturbance, more likely to see seizure in the early stages. Seizure is kind of an important one to bring up because epilepsy is quite common, especially in older years in Down syndrome. And there's a pretty tight association between epilepsy and dementia. They often go hand in hand here. Not surprisingly, a lot of the tools that we use to assess cognition, like the MoCA, are not validated or normed for Down syndrome. There are a few other tools that have been developed specifically for intellectual disability or sometimes specifically for Down syndrome. I think they're not things that I've used. I think they're kind of clunky unless you have a little bit of training or expertise, but they are available. The differential is pretty broad, and I think this is a really key part of the workup and kind of confirming the diagnosis. So a lot of these things on the differential are things that are already very common in Down syndrome. So hearing loss and vision loss, which we'll talk a little bit more about, hypothyroidism, depression. I think one other thing I'd like to call out is the psychosocial factor. So a lot of times folks with Down syndrome may have really close family supports or caregiver supports, people who they've come to depend on a lot. They may be very routine oriented. And so when you're talking about, deaths in the family or caregivers leaving, retiring, or any kind of family upheaval, moving out of the family home and into like a group home, these are all things that can be really disruptive and manifest as behavior changes that might be confused with dementia. And then another really big one is OSA. So making sure that we're considering that on the differential, making sure that folks have had a sleep study and that we're rolling that out. There is a little bit of guidance on this from this national task group that was put together, I think about 10 years ago. And they did come up with these consensus recommendations. It's kind of a 9-step approach, and it really just amounts to putting together a really thorough history. There's not a lot on here that's pointing towards physical exam or imaging, lab studies, biomarkers, or even recommendations to use those cognitive assessments that I already mentioned. A lot of it is just guidelines on how to really collect a comprehensive history to kind of nail down this diagnosis. And so starting with a really firm baseline functioning, preferably before the age of 40 when we know that the prevalence starts to increase, and then assessing annually after that age, using caregivers and parents, folks who know the patient well, and then considering a broad differential. In terms of treatment, there's not a lot that we know for sure. There have been a few small clinical trials specifically in people with Down syndrome. Mostly, the best evidence is for donepezil and memantine. And I'm sorry, I don't mean to say that that they have good evidence for efficacy, more that we have good evidence for their overall effect. Unfortunately, it hasn't been great. So donepezil, there's kind of a hypothetical role here, given that we know that there's cholinergic deficits in adults with Down syndrome. So it kind of stands to reason that acetylcholinesterase inhibitors might play a role. However, the Cochrane review that came out about 8 years ago did not really find any significant improvement in terms of different cognitive domains that were looked at. It's kind of a small sample size at 192. Follow-up was limited to no more than 24 weeks. And if you actually kind of dig into the individual studies, I think there's a little bit more room for optimism in terms of, maybe 1 or 2 of the studies finding some improvement in 1 or 2 of the cognitive domains, but when kind of combined into the meta-analysis, there's no statistical significance showing improvement versus placebo, and in fact, more adverse events, which is, not all that surprising. But I think the jury's kind of still out for acetylcholinesterase inhibitors. For memantine, there's actually a pretty decent study showing no significant advantages over placebo. This is from 2011 with 173 adults. However, that being said, there is a good study that shows a possible survival benefit. This was a study that looked at predictors of survival after diagnosis with Alzheimer's disease. One of the kind of subgroups they looked at was patients who were receiving anti-dementia drugs. And so they included both donepezil and memantine, as well as a few others. And what they found is that after diagnosis, the group receiving treatment had a median survival of 6.14 years versus 3.25. So somewhat significant. I think it's got limitations. There may be some confounding from other areas where the folks in the treatment group had improved care or follow-up. But it's something to consider. I think kind of putting that all together for me, if I were to be engaging in shared decision-making with a patient on whether or not to start these medications, I'd be looking at this. I'd sort of be looking at, what does increased survival look like without concrete improvement in quality of life and without concrete improvement in, the symptoms of dementia. That being said, especially with donepezil, I don't think we can really say with much confidence at this point that with a larger powered study, we wouldn't see some degree of benefit, more like what we see in the general population. So I think, that's where I would kind of land. And it seems like the expert opinion tends to be that donepezil in particular may be worth a try more so than memantine. A few other things under investigation, antioxidants, kind of targeting that oxidative stress mechanism of disease. Pretty big study, didn't show any benefit from vitamin E. In terms of anti-amyloid stuff, the expert consensus on aducanumab is to kind of hold off at this point in Down syndrome. There's sort of a hypothetical concern about, with the higher than average proliferation of amyloid plaques in the Down syndrome population, that there may be more risk of hemorrhage. So something to consider. And then a few other things that are kind of ongoing. So I think at this point, the strongest recommendations that you can kind of draw from the evidence that we have, the importance of establishing baseline functioning, annual assessment starting at age 40. I think this is something that probably deserves like a 40-minute or hour-long visit every year. Really involving family and caretakers, keeping a broad differential, making sure that folks are up to date on TSH screening, which should be annual, OSA screening, and then kind of shared decision-making when it comes to treatment options. So moving on now to sensory impairment. I think, with vision impairment, hearing impairment, it kind of follows a pretty similar trajectory. where you're going to see some degree of baseline hearing loss at, right from the get-go. So for hearing, 15% of newborns will have some degree of baseline congenital hearing loss. That can be from anatomic characteristics. We know that somewhere between 40 to 50% of patients with Down syndrome will have stenosis of the external auditory canal. That can predispose them to infections. It makes it really hard to examine the tympanic membrane. It makes them predisposed to kind of recurrent cerumen impaction. It kind of sets them up for hearing loss throughout life. Other anatomic differences, inner ear dysplasia, so malformation of the ossicles, cochlear nerve deficiency. There's a really good review for otolaryngologists by the Zalzal group.
They're so good.
Yeah, have you read this? Oh, sorry. So that's from JAMA from a few years ago. I think it's really applicable to primary care physicians, especially because a lot of the things that they detail in terms of audiology and ear infections are things that we deal with a lot. So probably worth a read. Frequent or chronic middle ear infections are quite common throughout childhood. One study reported a prevalence of over 60% of chronic otitis media with effusion. A lot of these children will end up with multiple rounds of tympanostomy tubes, chronic perforation of the TM, cholesteatomas. These are all things that contribute to conductive and sensorineural hearing loss later in life. And then as folks age, one study found that, the presbycusis, what looks like presbycusis is really starting already by the second decade of life. Vision impairment kind of follows a similar course. Nearly every structure of the eye is subject to anatomic abnormalities from birth. And then the progression of age-related vision impairment begins decades earlier than in the general population and is typically more severe. There's thought to be a component of sort of the neuropathology of Alzheimer's disease present in the visual association cortex. And then you also have oxidative stress contributing to cataract formation. So a cross-sectional study from Scotland estimates that by the age of, their mean age was 41, there's a near 50% prevalence of visual impairment, near 40% for hearing impairment. This study that collected audiometry data on 257 adults found a weighted prevalence of 57% for hearing loss, and it tends to be more moderate to profound than in the general population. So for folks over 50, moderate to profound hearing loss was present in up to 62%, whereas in the general population, there's more of a skew towards mild hearing loss as opposed to moderate to profound. So kind of looking at that in graphical form, these studies have demonstrated that, age-related hearing loss will appear up to 3 decades earlier than in the general population. They kind of reach a point, by 60 years where it's almost universal, some degree of hearing loss. And so they arrive at the conclusion that by the age of 50, it's, you almost assume some degree of hearing loss unless proven otherwise. Vision impairment, also very prevalent, also more moderate to severe than in the general population. Really high incidence of strabismus and cataracts. It can be tough also to make these diagnoses. Carers and health professionals often don't suspect it. They aren't aware of it. It can be tough to communicate the need on the patient's part for screening. Oftentimes it's misattributed to underlying intellectual disability. It can be tough to perform the screenings, especially when there's kind of barriers to communication. And we don't really know a whole lot about the effectiveness or tolerability of hearing aids and cochlear implants. So it can be tough to know where to go from there. So I think all this points towards the need to try to get folks to, specialists who have some degree of experience working with this population in order to get the most out of screening and treatment. So we don't have great evidence on guidelines for hearing and screening, hearing and vision screening. Some of the studies that I've already alluded to recommend audiometry every 3 years throughout life. I haven't talked yet about UCSF, but they have an office on kind of preventative care for people with disabilities, and they have a pretty decent set of guidelines. It's more comprehensive than what I've seen elsewhere, but maybe less detailed and less kind of backed with data. But their recommendation is for every 2 to 3 years, starting at 30, to have ophthalmology exams, and then hearing assessments every 3 years throughout life. Massachusetts has a Department of Disability Services that also has a pretty decent set of guidelines. They recommend, again, screening every 1 to 2 years. They're kind of targeting 22 for glaucoma assessment, and then every 1 to 2 years after 40. So I think kind of putting this all together, strongest recommendations are just to have a high index of suspicion, even when symptoms are not being reported. Include this in your differential for behavior changes, cognitive changes, dementia. Start young. I think a lot of the things that we can do are more preventative, especially with our pediatric population. So routine ear exams and cleaning, in hopes of preventing chronic otitis media, and then really low threshold to look for audiology, SLP, folks who may have some degree of specialization in this area. Unfortunately, I kind of did a search online for people in Boise who may kind of tout themselves as having, a lot of experience with this population for things like optometry or ophthalmology, and I really just couldn't find anything. So if anyone knows anyone, I think that would be really valuable, but I'm not sure that exists much in Idaho. And then making use of pneumatic otoscopy and the Weber and Rene tests when feasible. Next, osteoporosis. This is something that's thought to affect 1 in 4 adults with Down syndrome. The pathogenesis is a little bit different from what we see in the general population, and that has some ramifications for treatment. So a lot of the bench work in this area suggests that it's more a problem of reduced bone formation rather than the bone reabsorption that we usually see in more age-related osteoporosis. And this is something that's really starting right from the get-go, like in utero and early in life, with kind of primary bone formation. In addition, a lot of secondary causes, things like sedentary lifestyle, nutritional deficiencies, sunlight exposure, hypotonia, some of the other comorbidities like thyroid disease, hypogonadism. And then another thing to kind of point out is when you're looking at like DEXA reports, you have to keep in mind that due to like short stature and smaller bone volume, it's not a direct like apples to apples comparison of bone mineral density. Our standard BMD calculations are 2-dimensional measures, and so they tend to actually underestimate bone density in people of shorter stature and smaller bone volume. So something to keep in mind, and there are some workarounds on that, but it's not always available in the standard DEXA report. So 2 pretty good cohort studies have characterized the degree of the problem. The first one from Italy actually used what's called bone mineral apparent density, and that kind of factors in that smaller bone size. And so by comparing that to this larger population database, they were actually able to get sort of a 1-to-1 comparison. So that's really helpful. With that better comparison, they showed that folks with Down syndrome in the 40 to 49 decade had equivalent bone mineral density to people in their 60s from the general population. And then this other similar study in China similarly showed that the average bone mineral density of a man with Down syndrome was 20 years lower than a control at 50. So across these two studies, some of the consistent findings, people with Down syndrome tend to have a lower peak bone mineral density. They usually reach that peak at a lower age, and then following that, they'll have earlier and more rapid loss in bone mass. That happens faster for males. They'll usually reach peak bone mineral density at the age of 20. Females with Down syndrome generally don't start losing density until after 40. And interestingly, in both samples, kind of across the board, males with Down syndrome have a lower density than females, and therefore a higher risk of osteopenia and osteoporosis. For men, risk is about twofold to threefold higher for osteoporosis than men without Down syndrome. And unsurprisingly, this is a group, well, if you sort of generalize from all people with an intellectual disability, they're less likely to receive bone mineral density testing than the general population. Some things that I don't think are well answered from these two studies and the data in general. How well in this group does bone mineral density equate to the risk of osteoporotic fracture? How much can we sort of extrapolate these studies on bone mineral density to make decisions on pharmacological treatment? How prevalent are pathologic fractures in Down syndrome? How valid are DEXA results or the FRAC screening? And then we really don't know much about the efficacy of bisphosphonates or other pharmacological treatments. In terms of screening, starting with sort of the USPSTF baseline, they call out anyone or postmenopausal women under 65 who are at increased risk. So I think that kind of fits this category. One of the studies that I just cited, their conclusion was that, screening is appropriate in women with Down syndrome starting at 40, and then men even earlier if risk factors are present. And, they don't really specify what exactly they mean by that, but, I think you can glean from that if you have a man under the age of 40, for instance, who has a lot of the risk factors like hypogonadism, sedentary lifestyle, vitamin D deficiency, maybe it's worth screening. The other study that I referenced, they conclude that early screening programs are needed, but don't really specify further. The UCSF office calls out 40 for people in institutions, otherwise 45. And then the Tsu group that I really thought had strong recommendations, unfortunately, they found, when it comes to osteoporosis screening, they didn't really find the evidence sufficient to either recommend for or against any particular guideline and recommended shared decision-making. They did say that in the event of a fragility fracture, there should be an evaluation for secondary causes and treatment of any underlying predisposition. And then they also commented on bisphosphonates, which I think is kind of an interesting question. We know that these work by reducing bone resorption, and we have strong evidence to suggest that that's not the primary process in osteoporosis with Down syndrome. So when you consider some of the risks of bisphosphonates, I think it's kind of an open question of whether the risks outweigh the benefits or not, and we just don't have good evidence right now to come down on one side or the other. So overall recommendations, start thinking about osteoporosis and osteopenia at a younger age in patients with Down syndrome. Make sure that you're considering it in males just as much as females. I think the best thing we can do is to try and focus on the modifiable risk factors. So exercise programs, calcium, vitamin D, make sure we're doing the easy things. And then make sure that we're also screening for and treating secondary causes when pathologic fractures occur, or in people where you're just kind of concerned about fragility, falls risk, stuff like that, kind of covering your bases and treating what we're able to. And then when it comes to treatment, when we've made a diagnosis of osteoporosis, kind of proceed with caution when it comes to bisphosphonates and sort of weigh the relative risks and benefits. So kind of putting all that together, a few final thoughts. Primary care for people with Down syndrome can be a lot of work. you kind of consider all of the guidelines that we're already trying to meet in terms of care for people without Down syndrome, and then throwing on quite a bit of extra stuff to address all those co-occurring conditions and the premature aging. It can be a lot. And so I think it's worth scheduling folks for maybe a couple comprehensive visits a year, or trying to get them into longer slots. And then just make sure that we're also sharing the agenda with the patient, listening to their needs and concerns, also listening to caretakers, and make sure that we're kind of addressing anything that may lead to caretaker burnout, rather than, sort of narrowly focusing on our agenda and meeting all these guidelines. I think encouraging community engagement can go a long way in terms of quality of life, exercise, depression, and then sort of building a support network in the community that can help you kind of make these assessments in terms of things like dementia and sort of getting collateral from other folks. And then just, always trying to avoid pathologizing this condition. I think that can lead to assumptions, making assumptions about what people's abilities are, what people's values and desires are, what their learning potential is. That's something that varies quite a bit within this population. And then how people kind of perceive their own diagnosis or their own quality of life with Down syndrome, that can vary quite a bit. And I think you can sort of improve your relationship with patients by kind of taking their lead in all these areas. In terms of future directions, we've seen such a big increase in life expectancy. I think we can anticipate that will continue, and that will only reinforce the need to focus more research and kind of thought and labor into how we care for people in midlife and towards the end of life who have Down syndrome. There's a lot of room for improvement when it comes to generating an evidence base that's going to guide our care of adults with Down syndrome. We need to look at some of the screening assessments that we use for the general population and decide if they're valid in this population, if we need to adapt them or come up with entirely new tools. Hopefully that will lead to more concrete recommendations that we can use to provide preventative care. And then we need more trials of therapeutics that are specific to this population, taking into consideration that there are some, kind of ethical and sample size barriers to doing that. But, something to kind of guide these decisions that we're trying to make about things like bisphosphonates. This is kind of something that I just have as a work in progress, trying to compile some of these best practices. But I think at this point, I'll just take any questions that you all have.
Thank you, Dr. McShane, for the presentation. I really appreciate your time and all the great information. So if people have questions, you can either unmute or type your question into the chat, please.
Tyler, I don't have a question, but I thought that was a wonderful presentation, a really good review of the literature and kind of some things we should be thinking about. I think it will change my practice a bit, especially around thinking about hearing screening earlier in these patients. So thank you very much.
Cool, thank you.
Any other comments or questions? Feel free to unmute or type them into the chat. We have a comment from Dr. Kern. Thanks, Tyler. Well done. Anything from ISU? I just heard you go unmuted, so I wasn't sure if there was a question in the room.
No questions here.
Okay, I will mute you again. Okay, well, final call for any questions or comments.
And thank you everyone for attending.
And Tyler or Dr. McShane, thank you again so much. We are so grateful for you for being here.
Yeah, my pleasure.
We did record today's presentation, and so I'm in the process right now of finding a home for these recordings on the IAFP website.
Okay.
So stay tuned on that. And then for those of you that filled out the Google form that I put in the chat, we'll be getting your CME within the next month. I've just put more information in the chat. Our next grand rounds is Monday, August 14th at 12:30 p.m. Mountain Time with ERMAC, and the topic will be announced soon. You joined by the same link you joined today. And then I wanted to make sure people were aware that we are offering a July summer fall evening CME series this month. It will be Thursday, July 27th from 6 to 7 p.m. Mountain Time, Cultivating Resilience, Why Lifestyle is the Best Medicine. You do have to pre-register, and that link is in the chat. These are also all available on the IAFP events calendar from our website. We are offering another CME series on August 24th on gun safety in primary care. And then on September 21st, we're going to be talking about Alzheimer's in primary care in the evenings as part of our summer fall CME series. Dr. McShane, if you would send me the PDF of your presentation when we send certificates around, we will make sure that attendees receive the PDF. And is there anything else you'd like to say before we close today?
No, just once again, thanks everyone for attending.
All right, well, thank you all for being here. We hope to see you again at the end of July in the evening and next in August for our next grand rounds. Thank you all so much, and I'm going to close the meeting now.
Oh, hey, Liz.
Yes, I'm still here.
I was wondering, could you send me the recording once you